to another exciting academic web series under the aegis of Mumbai Hematology Group. Today is Thursday, 25th of June, 2026, and this is a series of mini series which probably is in the league of global records under Mumbai Hematology Group, and we at Intas Oncology are extremely proud to be a co-partner in this academic web series. Today we have two very interesting and exciting topics to be discussed, and all this has been possible because of Mumbai Hematology Group and our program director and moderator, who needs no introduction, somebody who epitomizes proactiveness, somebody who epitomizes academic excellence and clinical excellence, and delivering his content with a lot of simplicity at the same time, extremely intriguing. None other than Professor Dr. M.B. Agrawal. No wonder all of us are his huge fan. Sir, thank you for being a part of hematology and guiding the entire fraternity across the country. Over to you, sir.
Thank you, Dr. Manoj. Good evening to one and all. Today, as was mentioned, we have two guest speakers, one from India, one from US. The first speaker is Dr. Avriti Baweja from Dehradun, and the second is Professor Redditch from Seattle. Dr. Avriti Baweja will be speaking on From Continuous to Complete, 2026 Roadmap for Deep Remission in Waldenström. This webinar is brought to you by Mumbai Hematology Group. It is supported by Intas, Glenmark, Novartis, and managed by Perfect Square. I thank Team Novartis, Intas, and Glenmark, Mr. Yash, Mr. Kalpesh, and Team Perfect Square, Executive Committee of Mumbai Hematology Group, guest speakers Dr. Avriti and Dr. Redditch. All our discussants are themselves eminent hematologists, medical oncologists, and you participants for sparing your Thursday evening. Next Thursday, 2nd July. Our first topic will be Genomics of DLBCL. Are we ready? From Dr. Neeraj Arora from Ahmedabad. And our second topic will be an update on CLL from EHA 2026, Professor Wojcik from Poland. Few words about Dr. Avriti. She's MD Internal Medicine. She's DM Clinical Hematology. She's Associate Professor, Consultant Hematologist at Cancer Research Institute, Himalayan Institute of Medical Sciences, Swami Rama Himalayan University, Dehradun. She will be speaking on Waldenström macroglobulinemia, From Continuous to Complete, 2026 Roadmap for Deep Remission in this disease. I'll stop here and request her to share the platform.
Thank you very much, sir, for providing me this opportunity. So at the outset, I'm thankful to MB Agarwal, sir, and Mumbai Hematology Group for having me here. Today, I'll be discussing about From Continuous to Complete Care, 2026 Roadmap for Deep Remissions in Waldenström Macroglobulinemia. So basically, Waldenström macroglobulinemia was first described by Jan Waldenström. He said that it is multiple myeloma with a twist because he could see in two of his patients, he could see features which were somewhat similar to multiple myeloma, but he could not explain it because of its chemistry to be related completely to multiple myeloma. So it is basically an entity which is somewhat myeloma-like, somewhat lymphoma-like. Basically, Waldenström macroglobulinemia is a disease with two problems. First is the presence of lymphoplasmacytic infiltrate, and to call it a disease, it should be more than 10%. And the other component is the presence of monoclonal IgM protein. So basically what happens, the cells become confused. LPL is a peripheral B lymphocyte which is stimulated to differentiate into a plasma cell in response to an antigen or to a post-germinal center cell that has undergone somatic mutation but without any heavy class chain switching. Here, unlike what we think that it is more like myeloma, but the gene expression profiling is more similar to chronic lymphocytic leukemia than multiple myeloma. There is an increased recognition that LPL is a heterogeneous disease and it has two biological subsets with different features. Some are inflammatory features and some are non-inflammatory, depending upon whether it is arising from plasma cells or memory B cells. So it's an IgM secreting LPL. There are other LPLs which are less than 5%, but and IgM secreting LPL is the commonest one. It has got a strong familial predisposition with a positive family history, with a median age of diagnosis being 71 years, and males more than females are involved. It has a familial clustering such that nearly 1 in 5 patients with Waldenström had a first-degree relative with a B cell disorder. So here, family history and family counseling becomes very important. So the morphology is the typical lymphoplasmacytic cells with a phenotype which has a surface expression of pan B cell antigens, including CD19 and CD20, with a dim expression of CD22 and presence of CD25, 27, and IgM has added on to its diagnosis. It is negative for CD5, CD10, CD23, CD10, but sometimes it can be seen in some about 5 to 20% cases, it can be CD5 positive or CD23 positive. There are multiple cytogenetic abnormalities associated with it. It is seen that Waldenström has median of 2 to 3 chromosome abnormalities per patient. Deletion of 6q is the most frequent chromosomal abnormality, and deletion 17p and TP53 can be associated in 15% of the patients, and presence of TP53 mutation, like other diseases in small set of patients, is associated with poor prognosis. So the basic genes involved are the pathways, are the MYD88 mutations. In 93 to 95% cases, it is basically a L25-6P, and rest it is a non-L26-5P MYD88 mutation. So the pathway that is affected is the toll receptor pathway, in which the MYD88 is affecting the NF-kappa beta pathway, and after that it is creating a proliferation response in the lymphoplasmacytic cells. It also creates a cytokine milieu, which is also responsible for some of its constitutional features. The other mutation which is seen in Waldenström is the CXCR4 mutation, which is seen in 30 to 40% of our Waldenström patients. And it has got more than 30 varieties of mutations, among which nonsense mutations and frameshift mutations are commonest. And among these, if the nonsense mutations and frameshift mutations are present, it suggests that there is a high disease burden. It is associated with high serum IgM levels and hyperviscosity, and it produces BTK resistance except for zanubrutinib. So when we compare the survivals on the basis of whether it is a wild type of a MYD88 or a wild type of CXCR, or it is a mutant one, we have a prognostic significance. It has been seen that the two mutant forms, that is the MYD88 and the CXCR4, represented with the green line, is somewhere in between the two varieties of the mutations. Then the one with wild type, both MYD88 and CXCR4, is having a poorer overall survival, and MYD88 mutant with the wild type CXCR4 has the best prognosis. Now, sometimes it is like that, why the fourth one is not mentioned. It is seen that if a wild type of MYD88 mutation is seen, it is unlikely to have a CXCR4 mutation with it, and even if it is present, it is usually rare. Apart from that, there are other mutations which can be detected on NGs. However, we commonly detect the two mutations. Now, coming on to the IgM related phenomena. So for that, we have certain terminologies which we should be knowing. First is the MGUS, that is the monoclonal gammopathy of undetermined significance, in which there is an IgM component, but there are no symptoms related to tumor mass or infiltration. The marrow infiltration is less than 10%, and there are no symptoms related to IgM. Then the smoldering, it has got an IgM component, and we have marrow infiltration more than 10%, but we don't have symptoms related to tumor mass or infiltration, nor we are having symptoms related to IgM mediated disease. Then there are certain conditions which are IgM related disorders, which could be a cold agglutinin hemolytic anemia, type 2 cryoglobulinemia, neuropathies and amyloidosis, in which we have an IgM component, we have infiltration, and we have IgM mediated symptoms. But demonstration of marrow infiltration at times becomes a difficult task. And the full-blown macroglobulinemia has all the features except the symptoms, which could be plus and minus depending upon whether when the patient is presenting. So the manifestations of Waldenström, first is the infiltration, in which hemoglobin is the one which is firstly affected. Apart from the high infiltration of the disease, which is reflected by decreased hemoglobin, we can have a component of iron deficiency anemia because of the hepcidin mechanism. Then there are features related to hyperviscosities, which include epistaxis, headaches, and impaired vision. Then there is a condition in which CNS is involved, having features like confusion, seizures, etc., which is known as Bing-Neal syndrome. And then there is adenopathy. Though this adenopathy is seen in 20% at the first presentation, and it is more commonly seen at relapse. So as a diagnostic protocol, we need to do a serum protein electrophoresis with immunofixation, along with quantifications of the immunoglobulin, 24 hours urinary protein collection, then a SFLC ratio. We need to do a serum beta-2 microglobulin to assess the staging system as a part of prognosis. Then a bone marrow aspirate and biopsy are mandatory. And if the infiltrate burden is less, then we may have to do a flow cytometry to demonstrate the presence of lymphoplasmacytic cells. Then we can go for cytogenetic studies, which are done usually doing FISH and MYD88 mutation status is done. Then we do the imaging. Initially, CTs were done more commonly. Now, PET-CT is being commonly done. Then to monitor symptoms of viscosity, we may see the viscometers and see the involvement. Then a fundal examination is very important for evaluation of hyperviscosity. Apart from that, Coombs test, cryoglobulinemia, tissue stains for amyloid deposits, and also von Willebrand factor. We need to rule out the acquired von Willebrand factor also. And for patients where we are wanting to give rituximab, in that case, we need to do the hepatitis B and C screening. Here, this is the important parameter, that MYD88 mutation is mandatory. It must be done on bone marrow samples using PCR or allele specific or ddPCR. However, when the disease burden is low, we can use CD19 positive enriched cells, and at times Sanger sequencing or NGS sequencing can be used for MYD88 gene sequencing when we are not able to get any results from the above methods. Then CXCR mutation analysis is not currently considered mandatory, but now since it is available in India also, if feasible, we should do it, because our therapeutic armamentarium is increasing and we have genome directed therapies available. So the scoring system, initially the scoring system used for Waldenström was the IPSS scoring system, which included age, hemoglobin, platelet count, beta-2 microglobulin, and monoclonal IgM protein. But later on, it was because the system was more for the pre-rituximab era, then came the revised IPSS scoring system. However, it was not meeting the requirements required for the BTK era. Then came the modified staging system for Waldenström macroglobulinemia, which included albumin, age, and LDH, because age is one of the most important factor, because there are certain mortalities which are age related rather than being related to the disease burden person. With the current staging systems, we can see that the revision of systems of staging has changed the staging of the patients. Initially, some of the patients who were IPS low are now considered into low intermediate, and some of them who were high may be actually low. So these are the features related to viscosity. Why we need to understand this? Because this could be a medical emergency. So we need to identify the mucosal hemorrhage, the visual disturbances, the neurological features, and the cardiac features. If the symptoms are related to hyperviscosity, we should we should begin with plasma exchange immediately. Usually 1, 2, or maximum of 3 sessions are usually required for controlling the IgM levels. However, it is important to know that plasma exchange is not a permanent method. It is just temporarily reducing the IgM levels. So once we have controlled our hyperviscosity, we need to give the definitive therapy to the patient. These are the changes in the fundus before and after plasmapheresis. And these are the clinical features of typical cryoglobulinemia, which are present in patients with Waldenström. And post apheresis, we can see that the reticular pattern has completely resolved. So what are the guidelines for initiation of therapy in Waldenström? Hemoglobin less than 10 gram on the basis of disease. Platelet count less than 1 lakh. We should rule out the immune phenomena. Then symptomatic hyperviscosity, presence of moderate to severe peripheral neuropathy. Mild neuropathies at times can be tricky. So usually moderate to severe peripheral neuropathies are the ones which are usually targeted. Then presence of symptomatic agglutinins, symptomatic cryoglobulins, symptomatic autoimmune related events, and amyloidosis, which include AL or ALH type of amyloidosis. So in a newly diagnosed Waldenström, when we have an IgM amgus or a smoldering Waldenström, in that case, we have to observe the patient irrespective of the IgM levels. IgM levels solely cannot dictate the treatment for Waldenström. Then presence of features of IgM-related neuropathy, Waldenström, symptomatic cryoglobulinemia may respond to 1 cycle of rituximab, in which 4 to 8 cycles of rituximab may be given. Usually the regime is weekly 4. Then in case when the features related to treatment are met, in current scenario, the best options, if there are no logistic constraints, are BR or zanubrutinib. So we can see that the survival in indolent Waldenström and amgus, it's very clear that amgus has a better prognosis than IWM. Then half of the patients who had no symptoms had not yet been treated at 3 years after their diagnosis. And those patients who were kept on watch and wait approach, 10% of the patients had not yet been treated even at 10 years. So watch and wait is an appropriate approach when patients are asymptomatic at diagnosis. The risk of progression is approximately 1.5% per year. With rituximab, we can see that there is an overall response rate of around 30 to 45%, and time to progression is approximately 13 months if we are giving 4 cycles, and for 16 to 22 months if we are giving 8 weeks of injections. Then there are other regimes in which rituximab and cyclophosphamide were combined, which included RCHOP, then CDR, which was a commonly used regime, and it showed that it has an overall response rate of about 70 to 80%, with time to progression being around 36 months. Then nucleoside analogs were tried. Then later on, with more safer regimes coming up, rituximab has been combined with various proteasome inhibitors, and bendamustine and rituximab shows a very good overall response rate with a time to progression of approximately 69 months. So this is the regime which is commonly used for rituximab, cyclophosphamide, and dexamethasone. And you can see that it has got a good progression-free survival. At 5 years, approximately 69.4 patients were free of the disease. Then how the comparison between how the BR outshined R-CHOP could be seen in this trial quoted by the study done by Rummel et al., in which it was seen that bendamustine rituximab fares 3 times better progression-free survival than R-CHOP. Then proteasome inhibitors were tried, in which bortezomib was given. Then bortezomib was combined with dexamethasone and rituximab. Then even carfilzomib was tried in cases where peripheral neuropathy was a major issue, and there are studies with ixazomib along with dexa and rituximab. So the issues were neuropathy with bortezomib, then dyslipidemias and cardiac issues related issues with carfilzomib, and certain issues of infections with ixazomib. So CXCR4 mutation does not lower the response rate to bortezomib. So in cases where CXCR mutation is present, bortezomib also may be considered. So coming on to the BTK inhibitors, for BTK inhibitors, the commonly available ones at present are the ibrutinib, acalabrutinib, and zanubrutinib. And for this, there have been studies in the relapsed refractory settings, treatment naive condition, and the trial which brought it into picture more was the randomized phase 3 study, that is the Innovate trial, in which we can see that ibrutinib rituximab is doing a far better than rituximab alone. So, but if we have ibrutinib, we need other BTKs, because ibrutinib has resistant WM clones in future lines, or there could be intolerance and toxicities in 10 to 15% of the patients. It could, after a certain time, there are chances of progression. Then because of certain issues, there could be discontinuation of therapies, and we need options which are less non-specific options. So here is the chart where we could clearly see the difference between ibrutinib, acalabrutinib, and zanubrutinib, in which as the sites are being affected and the potency, the toxicity profile is changing. So the trend is shifting from ibrutinib to acalabrutinib and now towards zanubrutinib. Acalabrutinib in Waldenström, it is currently the most commonly used BTK inhibitors, and we can see that from the study, it has shown that it has got good progression-free survival in both treatment naive and relapsed refractory cohorts. Then studies have been done with combination of bendamustine, rituximab, and acalabrutinib. Here in this 6 cycles of bendamustine and rituximab were given, followed by 12 months of acalabrutinib orally, 100 mg BD, and it has shown that it has got a wonderful response. Like we can see from the cycle 7 heading towards cycle 12 and further, we can see that the burdens, especially in the CXCR4 mutated status and the MYD88 mutated status, we can see the difference. So we needed this drug because of because zanubrutinib has less off-target kinase activities, and it does not require dose adjustments with food. There are, if certain patients are oral anticoagulant, we don't need to modify the doses. And in cases of hepatic impairment, it can be given in normal, mild, or moderate impairment. And in severe hepatic impairment also, there is small amount of effect only. So we got these studies results from the Aspen trial, where zanubrutinib was compared with ibrutinib, and this is an important factor because the two BTK inhibitors together are compared in very few studies. So we can see that it is showing good responses irrespective of the mutational status of the patient, and it has got good, very VGPR rates as well. Then from the studies of Alpine and Aspen trial, we can see that zanubrutinib has lower incidence of adverse effects as compared to ibrutinib, except a higher rate of neutropenia, which was not associated with increased infections. Then zanubrutinib has demonstrated a low prevalence of cardiovascular treatment emergent adverse effect. However, apart from that, hypertension can be seen in the zanubrutinib arm, but it was more challenging in when it was given till a prolonged duration. So more challenging, not in the terms of that it is not manageable, but in terms of ibrutinib, the comparison is that hypertensive episodes are more common with zanubrutinib. So recurrence of ibrutinib intolerance events during zanubrutinib. Now, do we see those events frequently with Zana? It has been seen in the studies that even after ibrutinib or patients who have acalabrutinib intolerance, most of the patients didn't face any intolerance events with zanubrutinib. So that is why it is coming up more upfront in the guidelines. Then there are other agents, because most of the agents we are discussing are the covalent agents, and they are bound to develop resistance future. So non-covalent bonded agents like pirtobrutinib are being studied, and it has, in the Bruins trials, it has shown a good 80% overall response rate in patients even who have received prior covalent based BTK therapy with low rates of adverse events. Then some way back, ibrutinib and venetoclax, we were expecting a good response with venetoclax, because venetoclax is coming up in various diseases and it's showing very good responses. But though the responses with ibrutinib and venetoclax were very good, because we were giving two pathways, we were targeting two pathways together, the BTK and the BCL2 inhibition pathway, and it was showing good response only, but the study was stopped early because of the ventricular arrhythmias in some of the patients in the study. So overall, for patients with Waldenström macroglobulinemia at first relapse, we have an option of covalent BTK inhibitors followed by BR, or if the relapse is post-BR, in that condition, we can use zanubrutinib, and if the duration is more than 2 years, we can repeat the optimal fixed duration therapy also. Then this slide, I'm showing it just like the slide I was showing before was from AGH 2025, and this one is from AGH 2021. Just 4 years back, when we were talking about ASTCT at first relapse. Now we are not, like, in this first relapse, we are not discussing about any transplant or any other therapy. We are just discussing about certain therapies like BR, zanubrutinib, and other BTK inhibitors. So things are changing so fast and evolving so fast, and in 4 years, we have such a significant change. Then on second relapse, what we were talking in first relapse, now we are talking about second or later relapses. So we have options like venetoclax. It can be given irrespective of the mutational status, pirtobrutinib, BDRs, transplant in selected patients, and we can repeat the previous therapy according to the duration of responses. Now, how we are, like in 2026, how do we need to approach it? It's basically a genome-based therapy, where in a treatment-naive patient, if the patient is having an MYD88 mutation with CXCR4 wild type, BTK monotherapy may be preferred, and other options include benda-rituximab or PI-based therapies. If it is both mutant, in that if we require a rapid response, we'll go for plasmapheresis, and we'll go for a benda rituximab based therapy. And if rapid response is not required, we may consider zanubrutinib, or we may either go for ibrutinib rituximab or a bendamustine rituximab based protocol. Then if patient is having both the wild types, in that condition, zanubrutinib could be an option, or the other option is bendamustine rituximab or PI based regimes. And those who are symptomatic, previously treated with Waldenström, in those scenarios also we have good therapies according to the mutational status, and depending upon the previous exposures, we can change on the therapy, and later on we can add on venetoclax, pertobrutinib, other chemoimmunotherapies, or we can try with nucleoside analogs, stem cell transplant, and now trials are going on for CAR T cell therapy as well. So whenever we are talking about response, because every time we are discussing about MRD as a response endpoint, here in Waldenström, when a patient can survive with a watch and wait approach, in the asymptomatic for approximately 8 to 10 years, in that situation, maybe currently eyeing too much on MRD is not feasible. VGPR still remains the goal in treatment. However, studies are going for MRD, and it is showing that those with MRD negativity have got a better progression-free survival. But now, since our work is being done with VGPR also, and patient is saying asymptomatic for long duration with the current existing therapies also, so currently it is not used in clinical practice. So whenever we are assessing the response, apart from the biochemical parameters, we should also have a look for the lymphadenopathy parameters, or the presence, if there was any extramedullary disease, for its resolution. Then maintenance in Waldenström macroglobulinemia at present from the studies have shown no PFS or overall survival benefit. Then transplant holds an importance in cases of salvage, or in cases where patient is fit for a transplant in case of AL amyloidosis. Then allo-ascites, multiple studies have been done, but still it does not hold too much position in management of Waldenström macroglobulinemia. And now we have trials for CAR T cell therapies as well. So this is the overview of the various therapeutic strategies for Waldenström, where we can target the CD19, we can target the BTK pathways, we can target on proteasomes, we can target the BCL2s, the NFK beta pathways, we have alkylating agents, BTK inhibitors, and coming on studies with the BTK degraders and bispecifics like apatinib. So to summarize, after making a diagnosis with clinical presentation, biopsy, immunophenotype, and genetic studies, we need to know the symptom burden of the disease. And depending upon symptom burden, we need to assess the comorbidities and patient preferences. And we may go for either a fixed duration chemoimmunotherapy, or we may go for something like BTK inhibitors or continuous therapy. So the take-home messages are: identifying features of hyperviscosity is important to address before starting the therapy. Genomic mutations has opened gate for personalized therapies, and whenever feasible, it should be incorporated into practice. There is no role of maintenance. It is only a physician personalized, and CXCR4 or BCL inhibitors since we are having more BCL2 inhibitors, are the new additions in the baskets for management of Waldenström. So these are my references. Thank you.
Whole profile of how the treatment of this disease has evolved over the last almost about 40 years. You really updated us right up to what has been happening till today. So those of you who are interested in asking questions or sharing your experiences, you're most welcome. We'll also wait for the questions to be put up in the chat box. I can just say that last year, I was fortunate in attending the workshop on Waldenström in France. They do it every year. This year it will be in California. If you look at multiple myeloma and amyloidosis, when I was a student, we would treat them differently. And slowly, if you see now, the whole protocol of getting applied to amyloidosis. There is hardly any drug in myeloma which you don't use for amyloidosis. Exactly same kind of simile you can see between chronic lymphocytic leukemia and Waldenström. Whatever has been happening to chronic lymphocytic leukemia, in a short period, it is getting translated to Waldenström. So, as was beautifully brought out by Avriti, in CLL, you do all kind of genetic studies and see what kind of abnormalities are there. You look at 17p, you look at TP53, you look at IGVH unmutated, etc. Similarly, over here, you're looking at MYD88, which is present in almost mutated in almost about 90% of patients. And very aptly, Dr. Avriti brought out the question of CXCR, which somehow is not very popular as I see. First of all, it's a rare disease, but whenever you see, people have not yet been doing this very sort of left and right. And it is present in, as Dr. Avriti mentioned, in almost about 1/3 to 40% of patients. And it has a huge impact on the treatment because it's the mid 88 mutated Waldenström that responds beautifully to, say, Xano or even first generation BTKI. But when you come to that, if these patients have CXCR4 mutation, those 30-40% of patients, the response to BTKI alone is not good. And she also brought out the point that in this patient, in those patients, you have to go for the BTKI of second generation, that is Xano. And these are the patients who do best if you do Xano plus bendamustine plus rituximab. So only MYD mutated Xano. If you got that with CXCR4 mutated, Xano with bendamustine rituximab. And if you remember in CLL, we used to say that if it is TP53 mutated or deletion 17p, chemotherapy is detrimental. Exactly same thing over here. TP53 is present in about 5 to 7% of patients of Waldenström, but you should do it. Because if that is present, then here also, chemotherapy-based protocols are detrimental. They lead to newer and newer mutation. And those cases, as Dr. Avriti mentioned, the role of venetoclax comes in. So Xano with venetoclax with rituximab, the triplet, does best for them. So Xano is all over, irrespective. So if you are not doing the molecular workup, you can use Xano all across. But then you can add one molecule, adding BR if you have CXCR4 mutation, adding venetoclax and rituximab if you have got TP53 mutation. In our days, when I was new in hematology practice, we were doing plasmapheresis left and right because we were using rituximab as the sheet anchor of treatment. So we had to do plasmapheresis to decrease the viscosity. We were also using a lot of purine analogs, which Dr. Avriti did not even talk about because they're obsolete. They are of total historical importance. They led to a lot of myeloid malignancy, MDS, and all those things. No one uses them, but we use them. Fludarabine, we use cladribine, etc. for quite some time. And as she rightly mentioned, we used to always say that first save the stem cell because you will require autologous transplant somewhere along the line. Today, you don't even talk about it. She didn't even mention that you preserve the stem cell because they're not going to do autologous transplant. How the treatment has changed slowly over these 30, 40 years was beautifully brought out by Dr. Avriti. One more advantage of Xano is it crosses the blood-brain barrier. So the condition that she talked about, the Bing-Neal syndrome, if at all you've got a neurological presentation or complication of this disease where cells have gone to the brain, then Xano is the molecule which can go there. You can't use methotrexate and cytarabine-based treatment because they are ineffective for Waldenström disease. So a lot of indications for zanubrutinib-based treatment, and it is becoming one of the best BTKI for this particular disease. One thing also she brought out, which is very important, if you're giving Ibru or Acala, and if the patient has got side effects, intolerance, cardiac, bruising, bleeding, infection, whatever, you can switch over to zanubrutinib, because the incidence of side effect profile, and she had the nice diagram for that, is much, much, much lower. So a lot of patients who have problem with the first generation or even with Acala, which is second generation, may have no problem with Zanu. So intolerance, you can switch between the BTKI. Yeah, if it is resistance, then you cannot switch. Then you got to move to the newer agents, including venetoclax and chemotherapy based. So I think we got a question in the chat box, Dr. Abriti, for you. Dr. Surbi Agarwal is asking, WM from where to read? Okay. She wants to give you the you want to give the reference?
So I've read it from multiple articles, the textbook, and the guidelines, NCCN guidelines, AJH guidelines, and the various trials and studies on Waldenström, depending upon the references quoted there.
Sure. Boston is the center for all the research on Waldenström macroglobulinemia. Driven is the person. So you put that word in your Google and you'll get the most updated information on Waldenström. So go to PubMed, just last 1 year review article, and the moment you see Driven name, then you can read that, because that is like a god for Waldenström. Second question is from Dr. Gautam Santosh Panda. What is your opinion on starting low-dose beta blockers with BTKI as prophylaxis against arrhythmias?
I think so. I don't commonly use it in my practice. So I think so. We only give therapeutic if required. So, sir, would you be able to?
Yeah, so the suggestion from you is quite interesting. It's not the standard of care at all. First of all, even with the first generation BTKI, the risk of atrial fibrillation is not more than about 5 to 7%, or maybe at the most you can say 8 to 9%. So 90% plus patients will be giving beta blockers without any indication. And second, today when you are moved to second generation BTKI, especially Xano, the incidence of cardiac arrhythmias, including atrial fibrillation, has so markedly reduced that giving anything prophylactic like this, it's not like, PJP prophylaxis, you give Bactrim to everybody or acyclovir to patients. It's not like that. So this is not recommended. This is not standard of care, and one does not do that. Dr. Surbi Agarwal has asked another question. Basics to read from where, sir and ma'am? Winthrop textbook of hematology. That's the Bible. So even I say to postgraduates doing MD medicine, Winthrop is a very readable book with a simple English, simple science, and you can read that. There are others also. There's Hofbrand's book. There is Hoffman's book. There are various textbooks. Dr. Babita, you have a question or comment? You are muted, Dr. Babita, muted.
Thank you, sir. First of all, thanks for having me on this platform. And thanks, Dr. Abriti, for having a very comprehensive talk on the difficult topic. Just I have 2-3 queries. One by one, I will ask. First of all, you have very rightly said that there is the mutation in 90 to 95% cases, it is MYT88 L265P. My query is that when we say deep remission, what we have understood about the deep remission, that at the molecular level, when we do this testing, this mutation has gone, or what is the scenario? There is no mutation.
In deep remission, there are very few studies related to the MRD status, and it has the studies I could go through. There like 50 to 60% of the cases were having the absence of those gene mutations, and depending upon the sensitivities of the test, we can increase the depth of the mutations which were being studied. But per se, because we are waiting for symptoms to develop for starting a treatment. So practically, it is not being used commonly, because if we are waiting for 8 to 10 in an asymptomatic case where we know that the disease, the IgM is present, there is a clone present, and still we are waiting. So I don't think so that has got much relevance for clinical practice at present. So VGPR is something we are more looking at.
Then my second query is that
Just like to add something to that. MYD88 has to be done from bone marrow.
okay.
If you are going to keep looking at this, you'll have to keep doing bone marrows every 3 to 6 monthly. So this is not again standard of care. It's not recommended. The clinical remission, your blood counts normalizing, your IgM band disappearing, your bone marrow morphologically settling down, or at the most you can do flow, are good enough in the clinical practice. No one is looking at MYD88 clearance in any one of the trial or in clinical practice anywhere.
Right, sir. So then my second query is that every leukemia or lymphoma has the propensity to transform into the other types of leukemia or lymphoma. This Waldenström has this the propensity to transform into another. What is your comment, Dr. Abrit?
Ma'am, though it is rare, but definitely Waldenström can have an histological transformation to DLBCL, which is the most common histological transformation associated with this. And it has been seen that if there are the wild types of mutations in those scenarios, histological transformations are more common. And if we talk about the treatment, in that scenario, we'll just treat it as a normal case, like a normal DLBCL case, where we'll be giving an R-CHOP-based therapy to the patient, and if required, and if patient is fit, we may consider for an autologous stem cell transplant. But it is usually a poor prognosis in comparison to the de novo one.
So, Dr. You exactly any B cell CLPD register transformation is an issue. So here also you have this DLBCL, but at a small percentage. Little more problem is the amyloidosis. That this patient can develop 8% to 10% of patients can develop AL amyloidosis. You have to look out for the heart, look out for the nephrotic syndrome, look out for the neuropathy, look out for the GI symptoms, etc. And then that central block that Avriti showed you, IgM related 1, 2, 3, 4, 5, cold agglutinin, cryoglobulin, all those things. They all can develop in an uncontrolled Waldenström. So this disease has peculiar complications, not just register transformation.
Right, sir. So then in one of your slides, you have shown that family tree and the many pediatric population children. My query is that whether you have, though the adult age, that's more than 70 years age, you have shown in your slide, but whether you have encountered any pediatric population or any child less than 16 years of age, or how many children with this entity you have encountered?
Ma'am, in my practice, I have never encountered such scenario, but I believe that at times the LPLs, because there is a stage when patient may have cold agglutination disease or something like that. At least in pediatric population, we don't look at the angle and we are not thinking of that aspect, but possibly that could be a clone to, there could be an underlying clone to it, but I don't have any personal experience. It's just that on the basis of logic, because IgM, because there are certain cases where we see autoimmune hemolytic anemia, we are having an IgM protein, but we are not able to demonstrate a clone even in young patients also. So basically, because of the umbrella treatment of rituximab we are able to rescue ourselves from those scenarios.
Only 10% of patients have been under the age of 50, and the youngest patient published, he was in 30s. So under 30, at least you don't have to worry at all. Between 30 to 50, you may rarely see first of all, how many Waldenström you see in your life? So between 30 and 50, you may see a few, and then above 50, you start seeing the patients. So under no recorded case.
Sir, my last query is that there is one international Waldenström Macroglobulinemia working group. That working group is there. How far it has, what is its role, and how far it has contributed in the deep remission? What is our theme of today's talk? in carrying out this protocol, sir?
So exactly that is what I was just telling. Last year, the meeting was held in France. It was about 40 kilometers away from Paris. You go by a lovely train. It's a place called Shanty. And this year, if you're interested, around Diwali time, it is October middle, it is in California. So they meet every year, unlike the professional body that meet every 2 years or 3 years. So they meet every year. And Trivon is the head of all this activity. Yes, there's a question also put up over here, and you are also asking about deep remission. There is a question asked about the POD24 in Waldenström. So these are all very, very significant. Who are the patients who do well, who do not do well? Is those who are POD24 and those who cannot get into the deep remission. These are the patients who will have early relapses. On an average, once you give a fixed duration therapy, you've got about 5 to 7 years of relapse-free survival.
Right, sir. Thank you, sir. Thank you, Dr. Baveja. Thank you.
The center at Boston is named after Waldenström in his memory. And I think 80–90% of the world data and whatever research we talked about today has come from there and from Trivon.
Okay. Thank you, sir.
Anybody else has any question?
I have one question for Dr. Abhuti.
Yeah, Amit, yes.
How do you treat? So how do you treat acquired Waldenström disease associated with Waldenström macroglobulinemia? Acquired VWD. How do you manage those patients with acquired VWD associated with Waldenström macroglobulinemia? You're muted, Dr. Abhuti.
So treating the disease per se will treat the acquired von Willebrand disease component in the Waldenström. So basically, BTK inhibitors or the therapies which we are planning will check on the VWD component.
Acute episode, you can do 7.
Yes, sir.
Acute episode of bleeding, you can treat with Novo 7. And
Okay.
exactly what Dr. Avriti mentioned, you control the disease, the inhibitor may disappear.
IVIG has no role in this, sir. IVIG has no role.
IVIG, I will have to check.
Yeah, okay. Thank you.
Any other question for Dr. Avriti? If not, then I can just sum up this part of our presentation today, that we have come a long way. The treatment of this disease has metamorphosed very significantly from the days of urine analogs and autologous transplant. We moved to treatment using alkylating agents and then bendamustine, rituximab. Slowly, we have moved to the targeted therapies. BTKIs are playing a huge role, and Xanu is one of the one which is most effective and least side effect profile and can be used for any amount of duration of therapy. You can modify your treatment protocol by adding it to BR if there's a CXCR4 mutation, 30–35% of patients, and you can have those small number of patients, 5–10%, where there is a TP53 mutation, and those patients you could use again Xanu with venetoclax with rituximab. So venetoclax becomes the first line of therapy for those few patients. Amyloidosis should be searched for right in the beginning. CNS disease has to be treated with Xanu. All other complications you should keep watching out for. These patients can have mortality due to infections as well, both treatment related and the disease related. You should be careful about that. Your usual vaccination, your usual prophylaxis as you do for CLL applies here as well. So with that, Dr. Avriti, thank you very much for this lovely, lovely, lovely talk.
Thank you very much, sir.
He has already joined, so I think we can introduce him and get on with the second part of our today's academic activity. I will just share my screen to introduce him. A personality of his type does not require an introduction. if you have anything to do with hematology, you know Professor Reddish very well. We are very, very fortunate that he has been addressing us at periodic intervals and has taught us a lot of things, right? Starting from the pandemic, we have invited him to give a talk and he has never refused. Just 2 days ago, we heard him about his huge project on Myelomax. He's Professor, Clinical Research Division, Fred Hutch Cancer Research Center, Seattle, Washington. He's a member of the Clinical Research Division, Director, the Molecular Oncology Lab, the Kurt Einstein Endowed Chair at the Fred Hutch Cancer Research Center, Professor of Medicine, University of Washington School of Medicine. He's the chair of the Leukemia Translational Medicine Committee of the Southwest Oncology Group. He was the inaugural chair of the National Cancer Institute and National Institute of Health Leukemia Steering Committee, and a past member of the Board of Scientific Counselors of the NIH Genome Research Institute. He's the past chair of the CML Committee of the NCCN, a member of the European Leukemia Network CML committees, and is on the scientific board of the International CML Foundation and the Max Foundation. He currently leads the lab committee of the NCI AML Precision Medicine Initiative, and that's the talk he gave 2 days ago, and leads the foundation of the NIH program MRD in AML. His lab research centers on the molecular biology of response, resistance, and progression in adult and chronic leukemias. In addition, the CLIA Molecular Oncology Lab provides the molecular diagnostic support for many institutional US intergroup, international, and pharmaceutical trials. He was awarded the International CML Foundation Award in 2017 and the Washington Global Health Alliance Partnership Award in 2019 for his lab work on diagnosing CML in the developing world. Today, he is speaking to us on CML 2026. Is there anything left to talk about? So I'm going to stop here. Once again, I must say that we are very, very fortunate that we are looking at him and going to hear such a personality. Sir,
great. Well, thank you so much. That was too kind of a introduction, and I should probably have you talk to my mom sometime. I think that when she found out that a bone marrow transplant really wasn't a surgeon, I think she was very disappointed. So let me to my slideshow. Good morning, everyone. Can everyone see that okay?
Yes, sir.
Okay. So good morning, everyone. Glad to be back here again. Obviously, this is one of the great rhetorical questions of all times, because if there was nothing left to talk about, I wouldn't be here. But by way of introduction, we're not going to talk a lot about the lab stuff today. This is going to be a mostly clinical talk. If in the future you want some nuts and bolts about the lab stuff that we do, I'd be happy to come back on. But this will be more of a clinical angle, because in the past that's kind of gone over well here. So the old days, right? So before tyrosine kinases were invented, for those of you who are as old as I am, most CML patients had this stereotypic progression where they were diagnosed in chronic phase, and at about 3 to 5 years, they go into accelerated phase in a blast crisis, and the median survival of this disease was basically 6 years. Everyone would eventually go into blast crisis if they weren't transplanted. And that's my first laboratory work, was trying to understand this biological clock that happened in every patient. But now we've got, and this is a timeline of the drug approval in the United States. We have sort of an embarrassment of riches, and it's really a model of precision medicine and how fast things can move once you actually define a target for your pushes the pathogenesis of the disease. In case of the Philadelphia chromosome, that's a B cerebral translocation. So that was discovered in 1985. The chromosomal abnormality was found years earlier by Peter Knoll at the Windstar Institute, hence the name Philadelphia. But the molecular lesions of the B cerebral genes weren't found until a number of years later. And then we had, from that point on, really only 15 years until the first tyrosine kinase was discovered. And then after that, we have very rapid discovery of these so-called second generations, and now these third generation allosteric inhibitors. So it's really a remarkably fast engine of improvement. So now we have basically two ways that we can inhibit the downstream Abl tyrosine kinase activity. We can either block the ATP binding site directly by drugs that do that, imatinib, dasatinib, nilotinib, etc., or we can go off-site and inhibit this hinge area of the myristoyl pocket with these so-called allosteric inhibitors, asciminib being the first one. The potential advantage of that is that we think that a lot of the downstream toxicities of the ATP binding sites are that they're fairly dirty drugs. There are a lot of tyrosine kinases around, and you not only block this ATP binding, but you block it in all the other tyrosine kinases as well. And that probably goes to a lot of the toxicities. Whereas this is a fairly unique pocket that's only in the BCR-ABL, so you don't get a lot of off-target activity of this drug, or at least get less off-target activity. This is just kind of shows how far we've come. The main difference we've had by tyrosine kinases is really decreasing the patients who go into accelerated phase of blast crisis. So these are looking at from 1980 to 2000s accelerated phase. So this is before tyrosine kinases, after tyrosine kinases, blast crisis, similar reduction. Oops, sorry. And then if you look at survivals, this is data from MD Anderson of survival in chronic phase. As you kind of go up from decades to this is when you had hydroxybusulfan, interferon area, and here's now with tyrosine kinases. So this huge increase in survival is really what is why CML is just the model of precision medicine. And this is now looking at survival curves from people in North America and showing that over time, the expectation of people in CML, has basically risen to normal, so that in people with chronic phase who get tyrosine kinases can expect to essentially live the same as their non-CML age-matched reference group. We found that's actually true in the low and middle countries as well through work we've done with the Max Foundation. Max Foundation has given free drug to up to 100,000 patients worldwide with CML. When you look at the survival of those patients, it's essentially identical to CML patients who are given the medication in Northern Europe and the United States. So the main thing is access. Access is everything. Once you give the drug, people, no matter where they are, will live pretty much a normal lifespan. So this is the drugs we have available in the States now, going from imatinib, dasatinib through ponatinib and asciminib. They've been approved in the US, all of them except for ponatinib, which has not been approved for first-line use. In accelerated blast crisis, most have been approved. The ones that haven't, nilotinib hasn't been approved for blast phase. Asciminib yet has not been approved for accelerated phase or blast crisis. But all of them except ponatinib have been approved for the first-line setting. So the thing that's really remarkable about all of the randomized trials of imatinib versus any of the other second or third generation drugs is they all show the same effect on response. And so I'm just going to go through these very quickly. This is looking at the cumulative incidence of response, so-called MMR, or response down to a 4.5 log reduction in BCR-ABL. And you can see this is the delta between imatinib and dasatinib for both the MMR, which is 3 log reduction, and a 4.5 reduction. Better for the second generation drug. If we go to the randomized nilotinib trial, you get the same effect here. There's no difference between the different 2 doses of nilotinib, but you see the same effect between an imatinib and nilotinib here. You go to bosutinib, the same thing. The delta's a little bit less, but still present all the way through 5 years of follow-up. And same story with asciminib. Basically, this is looking at asciminib was such that you could have a randomized trial between asciminib versus basically dealer's choice of what tyrosine kinase you wanted to use. So you looked at all of the tyrosine kinases, you had a fairly big delta. If you looked at imatinib-based, a bigger delta, second generation, less delta. And while you don't want to combine all these trials, what's really remarkable is that, again, these are the four major randomized trials. You can see the MMR rates are basically doubled, and most of them are 1.5 times as much with a more important drug. Rates of blast crisis are much lower with the second or third generation drugs. But the curious thing is that, oops, sorry, it keeps doing that, is that overall survival, we can't see a difference. Now, we don't know if that's because since all these drugs are so good at overall survival that you'll never be able to have a big enough trial to see a statistically significant difference, or if that's just the way it is. And then that even though you don't get the deeper responses and the faster responses with imatinib compared to the other drugs, as long as you're on them, you'll have the same survival. So the early results of all randomized trials are remarkably similar. Early responses with the important drugs are faster than imatinib. You get less progressions, but somehow you're going to get the same overall survival no matter what you use. So one of the things that people have been focusing on with asciminib now, since you can't really show a statistical difference in overall survival, is to concentrate on the toxicities, because that might be a better benchmark. That might be what the angle of giving these drugs are now, since you really can't improve overall survival. And so if you look at and ask for more about toxicity, both compared to imatinib or compared to the other tyrosine kinases, they all have about the same rates of grade 3 toxicities, a little bit higher with second generation tyrosine kinases. But if you look at the amount of toxicity that leads you to discontinue, much less with asciminib. And so that's most of those off-target things. And so you find that if you look at in an odds ratio, the hazard ratio for treatment discontinuation is about half for asciminib versus the other drugs. So it tends to be better tolerated than the other second generation tyrosine kinases. Now, in trying to decide what drugs to go on, there's a variety of ways to use. And some people have thought about using, the various scores, the so-called score, the Hansford scores. These were all scores that were actually determined well before tyrosine kinases were adapted, but they somehow managed to translate into the area of tyrosine kinases. And what these are basically are scores, since we don't know when the CML started in someone, you have to have some kind of reference point. And so, essentially what it amounts to is that blast count, spleen size, and white count, while they're not perfect correlators with how much long you've had the disease, that they're okay. And so what the Hansford scores, the so-called scores, are really measuring is a rough way to approximate how long you've had disease, thus how long you are in the kind of progression continuum. And you can find from various trials that shorter overall survival, you can see in the higher so-called score, that's mostly from the IRIS trial, which was the imatinib versus interferon trial. Higher MRA rates and less progression with second-generation drugs, you see with higher so-called scores with the ENIST and decision trial, and higher MMR rates with bosutinib versus imatinib in the higher so-called scores. So that's what prompts many of us that when we use any scoring system that you like to use, if it's a higher one, to bias it for second generation drugs, because those people probably have a little bit more risk of progression. Newest kid on the block is the ELTS score, which you can basically plug in online for your age and your spleen size and blast count and platelet counts. You get a risk group, and they will divide you into intermediate, lower, high risk. In Europe, most of the people are in the lower risk groups. And again, this translates into, if you look at overall survival probability, if you're low risk, you do fantastic. And then the higher risk, as you might imagine for a prognostic score, do a little bit worse. So again, patients in this group particularly probably should think about getting a second generation or asciminib. Here, dealer's choice, and here you can get away with pretty much any drug. All of these drugs have side effects. Some of them are common, like myelosuppression and fatigue, but other ones have their own particular set of toxicities. And the good thing about these drugs is that in general, if you have something like a specific type of toxicity, like a pleural effusion, if you put them on another drug, they won't have that again. So you can usually find one of the drugs that the patient will be tolerant of. Although there are people, and we see probably we have to transplant probably 5 to 10 of these people every year who cannot take any of these drugs. They get the various wildest side effects. They're well documented. So there's always going to be a subset of patients that you just won't be able to find a drug that works. Particularly the problematic is there's some people who will have just profound myelosuppression with any of these drugs. And those patients, you can never get them on drug long enough to really get them to have an effect that will affect their risk of progression. So those are some of the categories of patients that we now still have to take to transplant if you just can never get them enough drug to change the natural history. Now, these are values from North America and Europe. So they may well differ in India, but in our neck of the woods, most patients will have some comorbidity that you have to consider when you pick a drug. And this is kind of the common ones that we have in our neck of the woods: hypertension, cardiovascular disease, diabetes. And again, one comorbidity, about 30% of patients will have some, 15% with 2, and 11% with at least 2 comorbidities. So common enough that you really kind of have to think your way through this when you pick your drugs. Kind of benchmark things that I think about for selecting frontline therapy is there are as we reviewed, second generation TKIs inhibitor, probably better MR rates. Why that's important, again, mostly for people who are high risk disease, you worry about progression, but also the deeper, faster response. Those might be useful in people who want to get off drug, especially younger people who might want to have children and the like. So if you're thinking that part of your disease strategy is to get them into a very deep molecular response and then get them off the drug, second generation or asciminib probably might be the way to go. But as we said, there's no really benefit so far in overall survival. If you look at the long-term data, the safest drug seems to be imatinib. We have a long track record of it now, and it seems to be the best tolerated of all of them, maybe because it's the less potent. Here are some things that you can consider. This is from a review series that's coming up in Hematologica in July. So there's going to be a large CML review series that's going to talk about all the aspects of CML care. So I'll push you to that series because it's pretty good, if I do say so myself. So here are the kind of things to think about. CML phase, obviously that's important for survival. And there you want a more potent second generation drug. Accelerated phase of blast crisis, you have to think about allogeneic transplant. Any of your type of scoring systems, against prognostic and overall survival. So the more potent TKI, the better. Cytogenetics, if you have additional cytogenetic abnormalities by some classifications, that means accelerated phase. So you should be thinking about a higher potency drug. Immunophenotype really is really important, except for those who you happen to do flow cytometry and you see a large number of lymphoid blasts, because those are probably people who may be going on to getting lymphoid blast crisis sooner than later, and that will kind of define your therapy. Transcript type is debatable. The only one that isn't debatable is a very rare P190 so-called, which you find in Philadelphia positive ALLs as well. Those patients do worse, need a more potent second generation. And there's a weird variation that's very rare of BCR-ABL that doesn't have the A3 containing ABL exon. Those patients, because it changes the actual BCR-ABL content on a protein level, they don't have the allosteric site, so that you can't give them asciminib. Point mutations have no prognostic value in CML, but other genetic codes can probably do, and we'll go over that data in a moment. So you can kind of pick the optimal drug using the aim of your therapy preferences. For instance, if you're a person my age, I'm really not worried about getting off drug and having kids. So any drug would work for me if your only goal is overall survival. So I would be fine with taking imatinib. Risk group we talked about, and these are my top 3 when I see patients. And comorbidities, But what might be most important to your particular patient it depends. It may well be drug interactions if there are some drugs that you have to consider, including PPIs. Cost can be very important, and so here, it's better to give any drug than no drug. So if generic imatinib is what's available to the patient, then generic imatinib is great. And so if you want to do a kind of a flow diagram, here's kind of how I think of it. If you're over age 70 and have significant comorbidities or low life expectancies, then that's fine for imatinib. If you're not in that, if you have a low score, then if you have a strong desire to get a deep molecular response, get off drug, you go to the second generation drugs. If you really don't have any desire and a low risk, then imatinib is fine. And if you have a high score, then you get a second generation drug or asciminib. So those are some of the considerations of starting therapy. Now, let's say we picked a drug. How do we decide that people are responding to plan? And when do we have to change drugs? So the single, I think, well, not single most important, but one of the most important things that came out of the IRIS trial, which was sort of a surprise to us, was that the BCR-ABL level, just by peripheral blood PCR, was so strongly correlated with event-free survival. So this is the original data from the IRIS trial. Where at the 12-month mark, depending on your level of molecular response, you had a dramatic shift in how you did Waldenström. And this finding has really paved the way to all of our monitoring strategies, as well as the trial design. At least in the States and Europe, all of the second generation drugs, the phase 3 trials used peripheral blood BCR-ABL testing at a year as their registry cutoff. So we didn't have to do 5-year survival trials. We didn't have to do 10-year survival trials. We could pick a drug in phase 3 trial at the 1-year mark. So that's sort of the holy grail for all the pharmaceutical companies in looking at precision medicine and AML and the like, is trying to find some marker that's so strong so you can turn long, ultra expensive trials into relatively quick trials. There's a variety of these schemes out here. This is the one that we kind of concocted with the NCCN guidelines, is early response of you want to see more than 10%, knowing that at the 3-month mark, often there are complicating factors in looking at their response. And most of that's because, especially in the developed world, or industrialized countries, most people are diagnosed with CML kind of on routine physicals and the like, so they're not really sick. So even though these drugs are well tolerated, they feel worse on them than they did before you diagnose them. So there's a tendency not to take their drugs or fight with some of the toxicities early on. So early on, you have to decide if someone doesn't have a good response, whether that's biology or whether that is just that they haven't gotten used to taking their drug and they aren't taking them religiously. If you really know that someone's taking their drug, or pretty convinced they are, and they haven't hit the 10% mark by 6 months, then you've got to pick a new drug, because that's that primary resistance is foreboding for patients who go on a progression. Basically, once you hit the 1% mark, that's the level that's associated with complete cytogenetic remission. Once you hit that mark, you've basically gotten your benefit as far as survival goes. And so you can actually settle for that mark and be fine. You want to go deeper if you want to gain some of the advantages of deeper response, and that is at 0.1%, we call that MMR a safe haven, because it's very, very unusual to have any resistance or any progression once you've hit MMR. And in fact, if you had MMR and a patient is having a sudden increase in their BCR-ABL and the like, you have to really worry that they're not taking their drug, because it's really, really rare for them to come out of that deeper response. And once you get to 0.01% and beyond, then you're talking about the possibility of discontinuing BCR-ABL therapy altogether. Now, what's really interesting is that this early response is pretty powerful. So, these are the curves where Marin basically determined that the 10% response was the best fit for progression-free survival. But this is a study we did on responders and non-responders, looking at patients who sort of at the outliers of response. So people who got an MMR within 12 months, which is the red group, a blue group, and those who didn't hit those marks. And so you're measuring your initial response here. And if you look at BCR-ABL over time, you can see that even up to 10 years, there's very little crossing over. So that initial, 6 months or so really puts you in kind of two camps. And so, accurate measurements early on really do predict kind of long-term BCR-ABL. It's kind of striking. And in this study, we were trying to figure out, and so this kind of shows that effect here. This is a study from Sue Branford looking at the 3-month response rate and then the 6-month response rate. So if you have a great response rate, then your survival, progression-free survival, and the ability to have an MMR is fantastic. If you take the other worst, the greater than 10% and greater than 10% at 6 months, these people's chance of getting an MMR is vanishingly small, and the progression-free survival is way, way worse. This is obviously a danger zone. Now, this is a very interesting group here, and this kind of shows the whole compliance issue. Here's someone who didn't have a 10% by 3 months, but they have less than 1% at 6 months, right? That has to be adherence. That has to be taking your drug, because the biology of the disease isn't such that you decided it. Your disease doesn't not respond at 10 months and then decide, oh, wait, I'm supposed to be a responder, and then suddenly you respond again, right? This has to be drug stuff. And it just shows that once you do that these people have the same excellent outcome as these people. So it's just a matter of making sure that they're taking their drug to get that additive effect. Now, this is going back to the difference in trying to understand why people go into these two camps. And this is, we did gene expression analysis on these several hundred people. And we found that if you just look at clinical variables, ELA test scores, so-called scores and the like, your area under the curve is really about a flip of the coin, and on whether you're a great responder or a bad responder, if you just take those things right here before you know anything at all about their molecular response. But if you look at a gene expression signature, that's actually pretty good. That's about 0.8%. And the really interesting thing is that when you look at genes, you can look at good responders versus bad responders. That's me. That's weird. Definition. And look at the genes that are that must be a recording that I did a long time ago. So I'm just going to voice over what that was. All right, good. I got canceled it. So if you look at the genes that are involved in predicting responders and non-responders, it kind of makes some biological sense. So you take all the genes and you do 1,000 models and you say what genes are in 10% of the models. The good responders, the asterisk, they're all genes that are associated with immune response. And the poor responders are all genes, or mostly genes, that have to do with metabolism and cell cycle. So it's really, and if you look at pathways, the top 20 pathways that are activated in good response, they're all immune and inflammatory. And all of these are all associated with NK and cytotoxic cells. So the immune response seems to be, before even you give drugs, seems to be incredibly predictive of who's going to be a good responder or not. And this just shows if you take the patients and you cluster them into what things we call regulons. So you look at transcription factors that are up or down regulated, and the genes that are associated with those transcription responses, that gives you a so-called regulon. And you can basically just start doing a Markov tree on whether these regulons are active or interactive. So inactive, if you have this group that the apoptosis adhesion is all out of whack, these are all patients that kind of cuts you into good response or bad response. And then you keep narrowing the curve for a karyotic initiation factor, which is a kind of a pan-global transcription factors. And if angiogenesis, apoptosis, and the like, you kind of whittle this down so you can get an odds ratio of about 10-fold of deciding who or what isn't based on these regulons of immune response. So predictors of response, these are just some icons of American culture who are, this is Jim Jarmusch, a director and producer I like. This is Tom Waits, who's a singer. They're friends, and they all also have big hair, which is kind of interesting. But here's a quote from Jim Jarmusch that supposedly was to Tom Waits that I think applies to genetic predictors of response. Fast, cheap, and good, pick two. If it's fast and cheap, it won't be good. If it's cheap and good, it won't be fast. If it's fast and good, it won't be cheap. Fast, cheap, and good, pick two words by. Unfortunately, my world, it's mostly fast and good, which means it's not cheap. So if you look at the things that are out there to do disease response, we'll talk about somatic mutations, which isn't fast. It's not cheap, but it probably is good. Gene expression profiling is not fast. It's fairly cheap. It may be okay. Genetic variants, BCL transcript type, it is fast. You get that. It's cheap, but it's kind of variable on whether it makes that much difference in response. And cellular markers, looking at immune function and composition at the time of diagnosis, it's purely fast by flow cytometry. It's not cheap, and again, it doesn't clearly predict response. What we do know is that when people become resistant, we can find mutations. You take a cell line that doesn't have BCR-ABL in them, and you pop a BCR-ABL in it and then grow it on culture, and you see what concentration of drugs inhibit that growth. And then you manufacture that BCR-ABL to have specific point mutations and do the same experiment and say how much difference is the inhibition factor based on a particular mutation. And so in general, these correlate pretty well with the clinical picture. It can help you guide therapy, but you will always have cases where you'll find a patient who has a mutation, and since these things take time to get back, you may have already changed drug, and the mutation comes back and it says that your particular mutation should not respond to therapy, but when you look at their BCR-ABL, it has, and vice versa. And that's just because it's a contrived system. It helps in picking out a first agent, but it's not perfect. When you talk about who to test, basically the basic guidelines to go by is whether you're using the ELN system or the NCNN milestone system. If patients aren't hitting their milestones, those are people to test for BCR-ABL kinase dominant mutations. These are from the ELN adaptation. So if you're really not hitting, your 1% by 12 months, that heat map I showed before, or if you've responded and then lose your response, those are the other classification of people that you should do ABL mutation testing on. Don't memorize this. Einstein said, don't memorize anything you can look up. You can look this up. This is the kind of the mutations that have to dictate a change. So nilotinib is not going to respond. If you have these mutations, nilotinib isn't going to work. Ponatinib, there's really no restriction. It's actually the one that works on almost all the mutations. It has its own problems with toxicity. But even asciminib now has mutations that affect the binding to the allosteric pocket. So these are ones that also you have to kind of avoid. Now, we didn't used to think that other mutations were involved in CML, particularly chronic phase, but that's mostly because we never looked. But now that we're looking at patients with myeloid panels, we find that they are, in fact, some of the usual culprits are in chronic phase at the time of diagnosis. So we talked here that about 20-30% sometimes will have some mutation acquired, and BCR-ABL is the most common, but 20% or so of patients will have other mutations, and here's kind of the run of them. And these are like the common myeloid mutations. The most common one in CML is AXL1, and there's more and more evidence now that that's associated with both primary response to therapy and resistance. So this is just a map of showing patients with CML, and these are patients who are kind of more resistant in the Adelaide series. See a lot of AXL1 mutations, a few B core and the like. And here's a graph of patients given their mutation and how often they get MMR. And you can see that if you have an AXL mutation, your chance of getting MMR is much less than patients who have no mutations or have some other mutation. So that's kind of a hint that AXL may be associated with primary response. This is work that we've done with the Max Foundation in patients from low and middle income countries, where we've done dried blood spots on resistance patients. So these are patients that with known resistance. You can see that patients have a mutation with tyrosine kinase mutation in a fair amount of patients. So these patients have ABL mutations at the time of resistance and AXL1. And then here with these are patients who don't have an ABL mutation at the time of resistance and still a fair amount of AXL1. So AXL1, prior slide, influencing primary response. And then these are patients with resistance, and you see sort of an enrichment of AXL1. This is looking at a couple of papers looking at imatinib treated patients, and they're looking at failure-free survival and with no mutation, other mutation of AXL1. Again, AXL1 is less than the others. And then this is looking at this peculiar thing that if you follow people with AXL1 mutations at diagnosis, they have a fairly high probability of later on getting an ABL tyrosine kinase domain mutation. The mechanism of that is poorly understood right now, but it seems to have been now reproduced in a couple of studies. This is looking again at major molecular response, failure-free survival, and tyrosine kinase acquisition in patients. Again, you can see the AXL1, they do worse somewhat than the other patients and get more mutations. But this is on asciminib, and what it's basically showing you is that asciminib doesn't help in getting rid of the bad prognostic significance of AXL1. In fact, it may be worse. And here's the failure-free survival of patients with asciminib. So that's even worse than that. And here's the probability of acquiring a ABL kinase mutation downstream. So asciminib, if you have an AXL1 mutation, asciminib doesn't help you, and it might be even worse than using a second-generation drug. One thing to remember is for these agents, we don't have this similar data yet in the asciminib, but it will probably follow suit with along the second-generation drugs. Is once people relapse on one drug, they'll often respond, but those curves aren't flat, and patients are not to be expected to have the same type of excellent outcomes they are if they're treated up front. And that's just Darwinian selection. That's not really no surprise. But if you look at a couple things interesting here, the percent of patients who have to discontinue therapy once they're relapsed on imatinib and then have to go back on another drug is relatively high, right? So that's kind of interesting. Almost a 70% discontinuation rate for these drugs after 2 years. And the complete cytogenetic response at least 2 years is not very high either, less than 50%. And the progression-free survival, 6 years down the line, it's only 50%. And then one study, a little bit higher with the bosutinib study. So the take-home messages here is that once people have to change drugs, discontinuation of this next generation drug is not uncommon at all. They have a lower rate of CCRR. And it begs the question is resistance forever? I mean, once you become resistant, is this always going to be a common theme of kind of just playing whack-a-mole? And you shouldn't forget transplantation, because the more drugs you go through here because of resistance, the more likely you are to go to progressive disease, and your chance of curing those people with transplantation is way, way less than if you transplant them in chronic phase. So the logic of picking a second-generation drug, if they're intolerant, you can pick whatever drug you want to, right? They will all respond fine. So if they're intolerant, you have to switch them, basically do the safety profiles, look at the comorbidities, and pick whatever one you feel comfortable with. If you're in second generation drug or resistance, if you start with imatinib, then it makes sense to go to a second generation drug. You can be guided by the specific mutation, but otherwise it's sort of dealer's choice of what other one fits the patient and what one you're comfortable with. If you start a second generation drug, it doesn't make any sense to go back to imatinib. You should go to a second generation, some other one, or ponatinib. If they have an Abl tyrosine kinase mutation, then pick accordingly or pick asciminib. And if they have no Abl tyrosine kinase mutation, then I sort of like ponatinib in that ponatinib is one of the dirtiest of the drugs. It covers lots of tyrosine kinases. And if you've got resistance, but you've got no mutation, then you know your resistance is by some other pathway rather than BCR or Abl. So you may not know what that pathway is, but your chance of blocking it's probably highest with a dirtier drug like ponatinib. So this is sort of the flow diagram of that whole strategy, where imatinib intolerance or resistance, when you go on, TKIs intolerance or resistance, and asciminib intolerance or resistance. So this is just basically a flow diagram of what I voiced over in the last one. So the last topic I want to talk about here is the whole idea of discontinuation, which again, when we first started doing this work, the CML stem cell, at least in the lab, you actually can't kill a tyrosine kinase. They just kind of look at you and grow slowly. So the stem cell seems to be independent of BCR-ABL signaling. So we figured, well, if that's true, you'll have to be on drugs for life because you'll always have a reserve of stem cells, and once you stop therapy, you'll just relapse. And based on BCR-ABL levels, most people with BCR-ABL, when they respond to therapy, have this very quick response, and then they have kind of a slow discontinuation or slow response that goes over time. There's lots of theories and mathematical models of why that is. I won't get into those now. But because of that, you can kind of judge about how long it would take to get rid of all your residual disease. And the mathematical models was that would be somewhere between 30 and 50 years. And the median treatment time to get to a 4.5 log reduction would be around 10 years. And you would need the chance of getting off therapy and being cured would be relatively low. So that kind of data made most of us think, well, you're going to have to stay on this therapy for life. Luckily, Francois Mahon in France, our colleague, apparently didn't read that mathematical literature because he had 100 patients which had been on therapy for years and had no detectable BCR-ABL. And he just decided to take them off. And we said, Francois, that's not going to work. And of course, he was right and we were wrong. This is the long-term follow-up of that group, showing about roughly 40 to 50% of patients stayed molecularly negative after discontinuing imatinib. And so that's now been, cottage industries. If you look sort of at the probability of maintaining treatment-free remission once you get off drug, kind of accumulation of the tons of trials we've now done, basically about 50% of patients, will never get a deep enough response to try the TFR. Those who try, about 25% of them will be successful. If those who fail, if you get them back into a DMR after a few years, about 11% will become successful there. So the probability of ultimately getting off drug is probably around 35% for patients once they start therapy. This is just a cumulative of some of the trials that have been out there. They all have different criteria of how long they have to be in DMR and how deep a DMR. But the basic strategy is, or basic take-home message is that for all of these things, roughly about 50% of patients, once you get them off drug, will be able to stay in DMR. And some of those are with still detectable BCR-ABL. So some of these people, for instance, in the last study, the criteria was 4.0 log. And a lot of those patients who just stay with that level of 4.0 after your discontinuation and don't evolve. And there's a lot of conjecture why that is, but no certainty. Here's some of the predictors of successful TFR. Kind of the reasons to think about doing it is if people have long-term toxicities, financial toxicity, fertility issues. So these are reasons that you might want to get off drug. But there are reasons that people don't want to. So there are a lot of people when you ask them to get off, if they want to get off drug, they say no, because it's a long shot and you spent years telling them they have to take their drug religiously, and now you're telling them they don't have to, and they don't like the sound of that. And they don't like the idea that this could possibly progress, even though it's a fairly low likelihood. The things that we know are kind of successful predictors of successful TFR is the longer you've had therapy, the better. That makes some sense. The longer your duration of deep response, the better. That makes sense. Undetectable by BCR-ABL, especially by digital PCR, that just means they've got a deeper response. That makes sense. Older age doesn't make any sense at all. I don't know why that is. Undetectable BCR-ABL by PCR after 3 months of discontinuation. So if they are negative at the time of discontinuation and they're still negative at 3 months, that's a good sign. And lower risk disease by SOCAL at the time of diagnosis. And this is just an example of some of those TFR possibilities based on your response. So the worst is that who didn't have a deeper response for less time. The best is a deeper response at more time. That makes sense. And again, here's just the time thing of MR, 4 years, whether you've been that long for 5 years or less than that. And again, that all makes sense. Here's another way of putting all of that together. Just kind of, again, a code of risk. For some reason, females are better predictive of TFR. We don't know why that is. It may well be that, your X chromosomes have the highest amount of immune genes on them, which may explain why females also have more autoimmune disease. So this may well be that, just as we talked about, good response being involved with immune pathways. This may well be just, again, another immune phenomena. Disease risk, higher SOCAL scores, are less likely to want to do this. There's some question about whether or not the type of breakpoint you have is important. And there have been some studies that have shown that that's probably because, if it's true, people showed a long time ago that the longer transcript has a 30 amino acid residue in it that's immunogenic. So again, that might just be mirroring an immune response. And just the various transcript levels. And we said, deeper the better, longer the better. The risk associated with TFR is the inability to recapture DMR. If you put back on drug, that's rare. That's probably certainly less than 10% of the time. There's this TKI withdrawal symptoms that happens, kind of a flu-like symptoms like that happen within the first 3 months. That's easily manageable and is relatively brief. And then there's progressive disease. We don't know what the denominator is of this, but we know that there's now a few cases of blastic transformation. For a reason we don't understand, this tends to be primarily lymphoid blast crisis, which is kind of unusual in the old days, but now is becoming more and more common, especially when people transform on TKIs. This just shows treatment-free remission in 2 studies, but the important thing here is the speed at which people regain their response once you have to put them on drug. So these people have now, this is the subset of this group that relapsed in TFR. And once you start them on drug, about 50% of them will go back into major molecular response by 8 weeks. So you luckily in this group, 90% recaptured MMR. In this group, 94% got to MMR 4. So they should regain the response really rapidly. You can, in fact, try this again. I would have never thought that it would be possible to, once you fail, to actually try it again and work, but it does. So here, people after second discontinuation, and if you break these up, kind of logically, it depends on how long you have been on therapy before you try it again. So if you are impatient, it's very likely that you're going to remain in second TFR. A little bit better if you've been in TFR second deep response for a longer period of time. We talked a moment about digital PCR. So digital PCR can be done 2 ways. It can be done with wells and tubes, where you basically take a sample and partition it into tens of thousands of different separate PCRs, with the idea that each of these wells, this is a fluid system, Each of these wells holds essentially one molecule of BCR-ABL, and then you do the PCR. You just say, is it yes or no, and then use the Poisson distribution to calculate the reaction. This, for those of you who like math, this is the first published use of the Poisson distribution in the literature from the 1800s. This was the death from mule kicks in Prussian artillery officers, which fit the Poisson distribution quite well. The other way you can do this is with the BioRad system and the QIAGEN system, which basically puts partitions your BCR-ABL target into soap bubbles and does the PCR in a bubble. So you just count the ones by a laser that become positive. This is a paper we did looking at your risk of BCR-ABL detectable or undetectable. And what it basically shows is that if your PCR, conventional PCR and digital PCR are negative at the time of discontinuation, you do spectacularly. But here is our PCR detectable, undetectable, but you do pick it up by digital PCR, and you can see a very, very large risk of relapse. So if you really want to get to a kind of a better test, the digital PCR is about 1/2 to 1 log more sensitive than most PCR systems out there. This is, again, just another way of looking at the same thing I told you about, just to reinforce it. Treatment duration, molecular response, and the duration is really the main 3 things that will help influence who's going to survive, who's going to have a successful TFR. So in conclusion, first-line therapy, everything works. Pick your drug depending on what your goals are with the patient. Asciminib has the same efficacy and probably less toxicity than second-generation drugs. AXL mutations are probably bad, and asciminib probably doesn't save you or the patient in that situation. Second-line therapy, intolerance, pick whatever you think is best on toxicity to avoid. Resistance.
You're muted, Dr. Redich.
Okay. Given that CML is going to become more and more increasing prevalence in our clinics, if you say there's either a 1 or a 10% chance of something going wrong, you're going to have a lot of cases in the future of either resistance or progression. So it's kind of important to understand how to deal with those issues, because unfortunately, we're going to be kind of burdened by our own success, because CML is here to stay, and your clinics are going to be full of CML patients that you'll have to worry about resistance progression, or may want to go with offering treatment-free remissions. And with that, I think I'm set. We won't be able to get to all the email, all the questions and stuff, I'm sure, today, but feel free just to email me. There's my email, and I will answer you, send information, chat, whatever. So with that, I'll close this up.
Right. Thank you so much, sir, for updating us. Sir has to leave early, so he has 10 minutes for the question answer. We've collected a few questions for you. If you can just tell us a few things about.
Sure.
Is there a particular patient profile where you'll prefer asciminib as the first-line therapy?
Yes. I like this in patients. You know, a younger patient is going to have to be on drug longer, right? And those are also the patients that you might be able to get into a deep response and get them off drug, so they can have families, etc. So that's a patient that I like asciminib on, because it's going to have, we think it's going to have less toxicity, which is good, and it gets people into as deep a response as second generation drugs, which is good. So that's kind of a profile I like for that. The other ones I like is people who have lots of morbidities, which in my neck of the woods is pretty high, especially metabolic syndromes with hypertension, obesity, liver issues, and the like. It tends to have less of a better safety profile for those kind of patients.
Right. Thank you, sir. The other question I have is, if somebody has got a grade 3 thrombocytopenia in the initial month of asciminib therapy, how should one proceed?
Well, I would proceed the same as you would with any of the low counts with any of these tyrosine kinases, because the first thing you do, you can try a drug holiday, and maybe take them off the drug, wait for the counts to recover, and try again. Sometimes the same drug works in a lower dose. Sometimes you have to switch to another drug in a lower dose. And if that doesn't work, you can try GCSF. I haven't had much success with that. It seems like there is a certain group of people who have injury to their stem cells by the time that they're diagnosed, and you can never get them to the space of giving them the drug safely that doesn't just wipe out their counts. The other thing to remember is that we've been wrong on most of these drugs dosages. And so, which is kind of, dasatinib, we started at 140 at first, right? 70 BID. That didn't work. That was too toxic. We went back to 100. And now people are doing 50. And dasatinib just goes to show about how a lot of this stuff doesn't make sense. Dasatinib's half-life is a couple hours, right? But yet we give it for a day. And in the lab, it has the effects on the biology of the cells for 3 or 4 days, which again, we just don't understand how these drugs work. And so certainly if you have a drug and have toxicity, on restart, consider starting a lot lower, because sometimes you'll see an effect at levels that will surprise you. And that's probably due to metabolism. We know so little about metabolism of these drugs, and almost none of these drugs can you get a drug level on. Right. And so for every drug in the cancer sphere that we have actually established drug levels on, Cytoxan, busulfan, and the like, when you look at drug per kilogram, there's at least a 10-fold range in people. I mean, in the old days when we gave busulfan and couldn't measure busulfan levels for transplant, we'd have to have the nurses and the docs count the pills that people threw up, because we had to kind of figure out how much they got. When we could finally go back and measure busulfan levels in patients retrospectively, we found that those patients who relapsed, their busulfan levels were vanishingly small after transplant. The people who died of toxicity, they were 10, 20-fold higher than they should have been. And then that's just and I'm sure with these drugs, it's the same way. There's probably, unbelievably different things that we don't understand with microbiome and other stuff that influences drug levels. And it's sort of remarkable that we get people into a space where it works without much toxicity so often. I'm always kind of amazed that given the black box as the human body, that things work as well as they do.
Right. If a patient has inadequate response to asciminib 80 mg per day, what will be your next step? Increasing the dose or adding another compound, or totally changing?
So if we're saying that it sort of depends on what level of incomplete response we're talking about and what the goals are, right? I mean, if you've gotten them to a B-stable level of 1% or below, and if your goal is survival, you don't have to do a thing, They'll get all the benefit of that. If they're a younger person and you want to push them into a deeper response, then your options are, first trying to increase the dose, because you can go a lot higher than the 80 in that drug. If you have to go to 200 for T315I mutations, for instance. So you can push it higher. But I wouldn't wait forever. I mean, because the beauty of BCR-ABL is you can measure it quickly, right? So if you raise the level and in 3 months, the BCR-ABL isn't going in the right direction, then you might as well just stop and try another drug, right? At that point.
Right. Long-term asciminib use, is there any additional toxicity?
We don't have the signal for that yet. We do not have the signal for that. So that's why we say the only one that we really know is imatinib. We're pretty clear that doesn't have any long-term major toxicities.
Wonderful. If there's an asymptomatic rise in lipase on asciminib, what is the action to be taken?
We usually recommend lowering the dose or discontinuing it for a short period of time, and then going back up and off, and that will work. Again, we don't understand some of these short-term toxicities that occur with LFTs. Bosutinib is another example, right? Bosutinib, the diarrhea of bosutinib, usually it's actually self-limiting after a while. We have no idea why that is at all. And there's even more to it. I know the person who ran all the bosutinib trials in South America. GI toxicity, diarrhea was barely reported ever in South America. And so like, is that diet? Is that genetics? Is that what? But it just shows how this whole black box thing, right? It's in the trials in South America, GI toxicity was not an issue with bosutinib. Showing you how little we know.
Question in the chat box. Do you ever attempt TFR for patients who in the beginning were in accelerated phase or blast crisis?
No.
Right. The next question is, your ASXL1 data showed that asciminib doesn't erase the penalty and over half acquire KD mutations, yet the frontline algorithm offers it almost universally to all the patients. Should baseline myeloid NGS panel be done when you diagnose CML?
That is that's a more than a $2 billion question, right? Right? both rhetorically and financially. No one yet in the guidelines is proposing that, but I would bet that within a year or so that will be proposed. So I think that if you have, it's more and more happening, and if you have the wherewithal to do it, the potential to do it, I am now doing it.
And if you pick up ASXL1, what's your action?
I just do a second generation drug, not asciminib. As you might imagine, Novartis will not be sponsoring any of those studies.
We'll take one last question from Dr. Babita.
Very comprehensive talk, sir. So in one of your slides, you have very nicely shown the treatment-free remission, sir, and have discussed at length about it. Sir, my query is that what is its duration? The duration which you have shown is very less, 1 year or the less than that. Sir, can it be lifelong in some scenario? What is your comment, sir?
So ask the question one more time. Sorry, I had a little problem with you breaking up again.
Babita, repeat your question.
I had a problem with breaking up. Someone else was getting on a call here and I got distracted.
Sir, you have, in one of your slides, you have very nicely shown about the treatment-free remission, sir.
Yeah.
Sir, at length you have discussed about it. But what is its duration? My query is that the duration which you have shown is very less, 1 year or less than that. Sir,
Yes.
Can it be in some scenario? Can it be the lifelong in some situation? What is your comment, sir?
Yes, it can be lifelong. The TFR, the French group have been following patients now up to 10 years.
Right,
So, but those were patients who were on drug for a long period of time. We're kind of pushing the envelope now and taking people off drug after 3 years or so. We don't know if that will be the same type of duration of TFR. I would guess probably not, frankly. But so far in almost all of the TFR studies that have been out now, 3-5 years, once that curve is pretty stable on the bottom, the term relapses are very, very few, surprisingly enough.
Right, sir.
Jerry, this is 8 o'clock for you.
Yes, I've got time for me to get on a call to Italy.
Thank you very much.
Thank you, sir.
Thank you so
Thank
much.
you very much, sir.
Bye.
And thanks, Jerry.